Good evening, everyone. Thank you so much for being here with us for the February CIS webinar. As you know, it is hosted by the Early Career Immunologist Committee, of which I am a member. My name is Yasmin. I'm one of the allergy immunology faculty at Vanderbilt in Nashville. We have a great case for you tonight. Dr. Saara Kaviany, who is one of our HEMONC fellows who is specifically interested in primary immunodeficiency, is going to present a case entitled Double Trouble, Twins with T-cell Lymphopenia. That is a little bit difficult to say. And her mentor is the esteemed, wonderful Dr. Luigi Notarangelo, who, as you guys know, has given his time 2 months in a row for this webinar. So thank you, Gigi.
My pleasure.
Go ahead.
Perfect. Thank you, Yasmin. So I am hoping to discuss an interesting set of twins that we are in the process of taking care of here at Vanderbilt. So they initially presented to us at about 3-ish weeks of age. They're now 5 months old, and the concern at presentation was for a severe immunodeficiency. They actually channeled through our immunology clinic initially with low TREC and severe T-cell lymphopenia. Quantitatively, we had a normal B and NK cell count. The twin boy had a TREC of 0 at presentation, and the twin girl had a TREC of 3.4. And given kind of our process of care here at Vanderbilt, they were admitted to our transplant service for further workup and infection prevention. In terms of our initial evaluation in these patients with very low TREC, we did a CBC, we did a CMP, specifically looking at the calcium. We did flow for lymphocyte subsets, looked at CD45 RA and RO ratios, looking at immunoglobulins, and then the mitogen antigen stimulation as well. In the second line testing, we did some maternal engraftment studies, a TCR repertoire, and then sent off the primary immunodeficiency panel to Invitae while we were doing maternal CMV testing and clearing her for breastfeeding, as well as HLA typing for potential transplant. So just to kind of start by going through the labs over time. So this is for the baby boy, and you can see September 2019, which is our first evaluation at about 3 to 4 weeks of life. His CD3 count was 86. In the far right-hand corner, I have listed the normal ranges for age. And you can see he was low in the CD3, CD4 compartments, in addition to his CD45 RA-RO ratio that's listed there. His TRECs, which we sent off to Mayo at that time, so the unit difference is going to be different than what we were getting on our newborn screen, but a normal should be greater than the 6794 listed to the right. He was below the lower limit of detection. He had a normal TCR beta evaluation and about 84-ish% on his PHA stimulation studies. His immunoglobulins are listed there with his IgG presumably at about a month and a half, 2 months of age, still largely his mom's, and then his IgM and his IgA, again, on the lower end of normal for his age. And his NK testing we did a little bit later on, you can see is still below the lower parameter. As we move towards the right of the page, you can see that most recently, as of about a month ago, his CD3 count was up to 436, as well as a rising count in his CD4 and CD8 compartments, still well below the normal ranges for his age, but improving overall. Sorry. When we move over to the baby girl's labs, overall, you can see that she had a more plentiful number of CD3, CD4, CD8s, and that seemed to stay stable, and there wasn't as much of an improvement in her counts over time, but she was in a much different situation than her brother. At presentation, her TREC was just over 4,000, and she's kind of remained in that in that zone. Her TCR-V beta as well as her stimulation studies remained within the normal limits for age. And her IgG was in the 500s initially and has dropped down to about 180 as she's getting closer to the 6-month mark. Again, as her maternal IgG is kind of waning. But her studies definitely much better than his, but they were both undergoing evaluation at the same time, and we kept in reversal isolation while we were doing this evaluation. So when we first saw these patients, kind of big thoughts that we were having, definitely we wanted to do the genetic testing looking for etiology for SCID or leaky SCID that would allow for some T-cell development. DeGeorge was on our differential as well, although neither were dysmorphic looking, and no known cardiac or midline cleft abnormalities on exam. We considered DOCK8 deficiency. We considered other syndromes that could potentially lead to this T-cell lymphopenia. Again, they were very well-appearing newborns on exam. And in terms of an oncologic process or a marrow infiltrating process, the rest of the cell lines were very reassuring. They had no signs of lymphoproliferation on exam. And for these twins in particular who were born at the late 36-week mark, we were not as concerned for prematurity leading to some T-cell lymphopenia that would only improve over time.
Saara, one question.
Yes.
You also look at what was the mother under any treatment during pregnancy? Any possibility that she might have taken immunosuppressive agents of any kind?
That's a great question. I didn't really address that at all, but the mom's pregnancy was very benign. She had no complications during her pregnancy, not even notable for any anemia that she was on iron for. So very benign pregnancy and delivery.
Okay, just important to keep that in mind because
Yes.
there have been cases with low TRECs due to usage of immunosuppressive agents by the mother during pregnancy.
Great point. She was not under any specific care from her physicians. So in terms of grouping and defining kind of where our twins lie in the spectrum, again, this categorization is well familiar to everyone on this webinar, but we are looking at absent T cell and lower B cell function. And so the classic or typical SCID, you're seeing a T cell count of less than 300 with the stimulation coming in at less than 10% of normal, which both of their stimulation studies were reassuring over time. They, luckily to date, really had no issues with postpartum infectious concerns or really as they were growing and thriving. Atypical or leaky SCID, you see a T cell count between 300 and 1500 and their PHA is about 10 to 30%. Interestingly, those patients can be accompanied with autoimmunity or lymphoproliferation or skin eczematous changes, in addition to some bowel disease at times. And our twins kind of fell into this variant SCID initially with T-cell lymphopenia, and we had no molecular defect that we had identified yet. I saw something pop up on the...
Yes, there was a question about CHH. Did you consider CHH as a possibility?
We did. The lack of dysmorphic features, as well as the very normal development in utero and post, kind of pushed us away from doing like a full skeletal survey at initial evaluation, but it was definitely one of our kind of syndromic diseases that we were thinking about. So just going through kind of our thought process. So like I mentioned before, these patients did not have any midline defects, but the thymic hypoplasia or aplasia that is known with DeGeorge can occur with lots of different mutations kind of along that deletion syndrome, the 22q11.2. And these patients typically have cleft lip, palate, small jaw, small upper lip or mouth. Their eyes can slant upward or downward, and they have abnormal setting of their ears, short statures. And as we know, their their underdeveloped thymus or their lack of a thymus is really what is putting them into this immunodeficient category. These patients also have a high rate of autoimmunity later on in life. So definitely we're pursuing a microarray and genetic testing to rule that out in our twins. But our suspicion was low given their exam. Another differential that we briefly discussed was DOC8. So autosomal recessive forms are associated with the hyper IgE syndromes. And the picture on the right kind of depicts the wide range of cells that are affected by DOC8 deficiency and kind of how the STAT signaling pathways, particularly STAT3 activation, is affected in patients with DOC8. So that ultimately is controlling your transcriptional activity, cytokine production, doesn't polarize your immune cells as effectively as you would see in a normal host. So these patients have migration, phagocytosis, as well as adhesion defects, which was considered in our patient. I tried to get a good picture of the twin girl as she, during one of her follow-up visits, started to have slightly more eczematous lesions on her skin, thought to just be sensitive skin, but unfortunately we couldn't get a good picture on her. So our genetic testing, we sent the Invitae primary immunodeficiency panel so that we make sure to include all of the most recent SCID genes. And what we found is a variant of uncertain significance in DOC8, as well as a variant of uncertain significance in FOXN1. And the microarray that we sent off looking for DeGeorge was negative. So I'm going to start the conversation kind of briefly about this particular FOXN1 mutation that we found, and then I'm going to have Dr. Pua, who's one of our molecular pathologists and weighed in very greatly on this case, chime in as well as Dr. Notarangelo in terms of what we see. So I copied and pasted the Invitae results on here just to show kind of how they had reported it out to us. So this particular variant in our patients is novel, but the frame shift mutation that we are seeing with this change is similar to several patients that have been reported in papers. And as we'll get into later on in this talk, the change is thought to affect the transactivation domain, which presumably would impact DNA binding. And as we affect DNA binding, we expect to have some larger impact on T-cell selective genes, as well as some of the other features that we'll talk about, such as affecting keratinocytes. So therefore, you're potentially seeing an effect on gene expression. But this was how it was reported out to us and kind of where we started to do some of the investigation. Heather, I don't know if you want to weigh in a little bit on kind of when we first saw the testing.
Before Heather, there was actually a question, did you look for a deletion on the other allele of FOXN1? And how would you do that?
Yeah, so I've spoken to Invitae a couple times. We did not do any particular follow-up testing on the twins, but we did do testing on mom and dad. And given these initial findings, we had actually pursued whole exome on the twins later on. And did not find anything else that they reported out. I believe in this report, Invitae talked about looking at deletion duplications. Mm-hmm. I have to go back and look specifically at how they had reported it out, but we had a follow-up discussion with them. Mm-hmm. And we felt comfortable kind of knowing we had maternal DNA as well as dad to kind of evaluate these variants.
Yeah, I should also add that, you're going to discuss this later on, especially the paper by Nick Van Ers. But if you have biallelic loss of function mutations in FOXN1, with both of them being loss of function, then you really have a nude SCID phenotype, both in humans and in mice. And obviously, neither one of these babies was showing a nude SCID phenotype.
Heather, I don't know if you want to chime in later in terms of how, upon our evaluation, we started to think that this may truly be a variant that was impacting our T cell counts and our clinical presentation, or if you kind of want me to keep going and chime in as we talk about the literature.
Yeah, I mean, I think I could I'll just speak a few sentences about how I would start to approach a case like this, and then maybe I'll let you present some more about the gene and chime in as you go along. So, my goal as a molecular pathologist is to classify the variant and not necessarily determine directly whether it's responsible for the patient's disease. And when I look at sort of an initial gene report, my eye is always drawn to frame shift mutations because they're likely to cause loss of function. And typically, we don't tolerate loss of function of genes very well. I think I would always first look in this case at the FOXN1 mutation because it's a frame shift mutation. I always begin by looking for reports of this precise variant as is listed below. I did this myself as well and couldn't find any reports of this specific variant in normal population databases and publicly available disease databases or the literature. But as was just mentioned, we know that loss of function variants in the homozygous state can cause disease, and frame shifts are good sources of loss of function variants. So I started looking in more depth about what types of mutations were causing disease or reported to cause disease. And the first thing I did is I looked at NOMAD, which is sort of this next iteration of EXACT. It just has more normal individuals. And what's interesting about this gene is that it does appear to be loss of function constrained. And what that basically means is that if you look at the predicted amount of frame shift and splice site variants in the population, you don't see it occurring as often as you expect. And sometimes this actually means that haploinsufficiency may cause a disease or may be deleterious to survival. It was not among the 10% most constrained genes for loss of function variants, but it was pretty close. And then I spent some time looking at variants in ClinVar and in the literature, and I know you're going to go into detail about that. And just what I want to say is that when we're evaluating frame shift mutations, we both want to look for whether frame shifts have caused disease. And I think that is definitely proven to be true in this particular condition with this disease, but also where the frame shift occurs. And I think that is one of the issues that will come up in your talk, and whether the frame shift includes loss of critical domains or results in nonsense-mediated decay. So whether we think that it really impacts function. And then I'll just say one quick thing on the DOC8 mutation. So again, usually these are loss of function mutations in DOC8 that cause disease. This is a missense variant. Couldn't find it reported as disease causing in any database. It's in a named domain that has no identified function. So I definitely think this is a VUS.
Perfect. Thank you. Sorry, I forgot to take the animation out of this slide, but Dr. Notarangelo's paper here focusing on the heterozygous FOXN1 variants actually leading to similar phenotypes with what we're seeing in our patients is where I wanted to shift the discussion to, and kind of how they came to this conclusion and why we think this is so important for our twins. So FOXN1 is a master regulatory gene for thymic epithelial development. So deficiency in FOXN1 leads to thymic aplasia, alopecia, nail dystrophy. And like Dr. Notarangelo mentioned, these patients typically, when you have loss in both alleles, account for this nude or severe immunodeficiency phenotype in humans or in mice. I do see the question that popped up about the changes in the parent, and I promise I will get there. But FOXN1 what we know is if you have an arrest in thymic epithelial cell differentiation, you can have this T cell immunodeficiency associated with a mutation. So out of this paper in JCI, they specifically look at the thymic architecture. So they looked at mice with homozygous and compound heterozygous FOXN1 mutations, and they isolated the thymi from these mice and processed them. And so the FOXN 1933-933 mouse is the mouse with thymic aplasia, and the FOXN1 089-18089 mouse. So the kind of two to the right, as well as the 933 and the 1089, those were both hypoplastic thymi upon evaluation. And what they saw is an almost complete loss of mature CD4 and CD8 T cells as a result of this when they analyzed the lymph node of these mice. Their subsequent figures demonstrated that you could see B and NK cells in these mice and in these lymph nodes. So that confirmed the T minus B positive, NK positive SCID that they had seen with some of their patient correlatives. But this kind of really nicely depicts that you have this thymic aplasia and hypoplasia spectrum that's developing as a result of these FOXN1 mutations. The next slide, sorry, I don't know why this isn't, there we go. The next slide kind of is to show the scale of this gene. So it's a 648 amino acid protein, and the N-terminal region is what has been implicated in the thymic epithelial differentiation, and the C-terminus is what is thought to be identified to contain the transcriptional activation domain. So the top part, the homozygous or nude SCID, those were mutations that had previously been published to cause a nude SCID phenotype. And the heterozygous variants are the ones in the black below. And this is from Dr. Notarangelo's paper with the large cohort of patients that they had identified. And those were all the mutations that they found. And so in these, the majority of these FOXN1 variants were frame shifts, similar to kind of what we were seeing in our patients' genetic testings. 4 of them were missense mutations, and the remaining 3 were either nonsense or splice site mutations or variants. So the variants kind of spanned across the gene, but 6 of them were clustered in this fork head domain, and 12 in that C-terminal domain, which we talked about briefly when we were looking at their in vitro testing, to think that this is potentially affecting some of the transcriptional activations downstream. Dr. Notarangelo, I'm not sure if you had any other thoughts on.
No, I think you summarized very nicely. Yes, that's exactly what, yeah.
Perfect. So this table also came out of that paper, which I think really demonstrated nicely some of the points on the right-hand side that I included. I apologize, it's kind of a busy slide, but I wanted to make sure we hit all these points. So these graphs depict lymphocyte counts in individuals who carry heterozygous loss of function FOXN1 variants. So they are demonstrating across the board an absolute lymphocyte count, CD19 count, looking at your NK cells and C, and then as you can see, kind of CD3, CD4, CD8 in the second row, and then your CD45 RA and RO. And the gray areas within these graphs are supposed to represent the normal ranges for these age groups. And each subject was actually represented by a dot of the same color at different age ranges. So moving back to the top, as you can see, lymphopenia was present in the majority of these FOXN1 infants at diagnosis. So they fall kind of below that gray zone of normal. And moving to the CD3 and the CD8 graphs, you can see that both the number of CD3 T cells as well as the CD8 T cells were significantly lower than normal ranges. The CD19 and the CD1656 look pretty normal, as you can see depicted in those graphs. And longitudinally, in that CD4 graph in E, you can see that the lymphopenia seem to persist kind of with time as these colors that represent the same patient kind of move forward in the timeline. And the severity of the defect was thought to be somewhat improved once they hit that 2-year mark. You can see that they start to fall much more clustered into that gray zone. But the CD8 count still remains quite below the normal. And so the haploinsufficiency that is associated with this T-cell lymphopenia was concluded to be most marked in the CD8 T-cell compartment.
Saara, maybe let me add one thing on this. Can you go back to that slide? So the very last column in each of these panels is actually adults. They're not the same individuals that are shown in the previous ones, from 0 to up to 3 to 10 years of life. Those are adults all coming from the same village in southern Italy, where there is actually a large proportion of the individuals who are heterozygous for the same FOXN1 nonsense mutation. And so basically when we went back there to that village and sampled all of these individuals, we realized actually that their lymphocyte count was now trending to be within the normal range, but they did remain, as you pointed out, largely CD8 deficient, and less so with the CD4 number. Most of them actually had a normal CD4 count. So it's interesting to see that in the adult population, now you see even better that over time, there is spontaneous improvement of the lymphocyte count, particularly in the CD4 compartment, not so much in the CD8. I should point out that normalization of the CD4 is largely due to homeostatic proliferation. So those CD4 are predominantly memory CD4 and not really naive CD4.
So kind of concluding from both of those papers that most infants with heterozygous FOXN1 variants had abnormal or low TRECs at birth, and they had this persistent CD8 T-cell lymphopenia while their CD4 count improved. And as we'll get into in the next couple slides, what's key here is that some of these patients did have recurrent infections. So it is important to keep that in mind as we're working up and keeping an eye on these patients and screening them. Interestingly, the nail dystrophy that was associated with some of these patients with haploinsufficiency was noted after the genetics were found and not initially striking upon diagnosis. And I think the last point in terms of the adults who were heterozygous for this, they had studies even done on their children, which demonstrated a normal CD4 count with a low CD8 count, and 60% of those patients had nail dystrophy associated with it. So kind of conclusions to take away from those papers is that FOXN1 haploinsufficiency is associated with marked T-cell lymphopenia early in life. You can see this progressive normalization, but persistence of CD8. So super important to still keep them on your radar, as these patients did have severe infections in some cases. This paper really quickly before we move into some of the infectious complications, I think depicted very nicely. Again, I'm sorry that I had left the animation in there, but this paper was titled FOXN1 compound heterozygous mutations cause selective thymic hypoplasia in humans. And what they showed is that thymic hypoplasia caused this T minus B positive NK positive SCID, where the hair and the mice of the nails of these mice were actually normal. And the mice harboring compound heterozygous mutations in FOXN1 had thymic hypoplasia, but normal fur and nail beds. And I thought this was a really nice depiction of that. And you can see that both the compound heterozygous as well as the autosomal recessive mutations had what they were calling this hypothymus.
Did you see the question about the stem cell transplantation in these patients? Do you want to address it now, or do you want to address it later?
Yeah, we can definitely talk about kind of management globally for these patients as somebody who wants to practice stem cell transplant and PID. We did a lot of searching and a lot of digging. I did not find any bodies of literature that really supported this in terms of moving forward with bone marrow transplant. Again, as you can see, the counts tended to improve over time outside of that CD8 compartment. So a lot of it was close monitoring and in terms of looking for past infections and moving forward with thoughts on prophylaxis, et cetera. I don't know if you have additional comments.
Yeah, so within the cohort actually that we reported, 3 of those infants had received a hematopoietic stem cell transplant before the FOXN1 heterozygosity was identified as being actually responsible for the phenotype. And so out of those 3 infants, 1 of them actually died of treatment-related complications, unfortunately. The other 2 did engraft and had no improvement in the T cell count, indicating that, in fact, this is not a hematopoietic intrinsic issue. It's a thymic problem. There's a question about would thymic transplant help? Well, the question is thymic transplant needed? I think Saara pointed out very clearly that in most cases, actually, there is a spontaneous recovery, maybe incomplete, but largely satisfactory recovery of the T cell count over time. Although there are, concerns for infections, as she's going to discuss this in a minute. I should say that when you have biallelic FOXN1 mutations, then yes, the thymus transplant is actually life-saving and should be performed. With single monoallelic variants and this tendency to spontaneous recovery, I would hesitate to perform a thymus transplant. But of course, you have to look at what is happening to the child. And so the child needs protection. You need to prevent infections. And if you see no improvement in the T cell count, number one, you should ask the question, is there a deletion really on the other allele or something that is impeding expression of the FOXN1 also on the other allele? And number two, in that case, you might consider a thymus transplant. But generally speaking, the heterozygous FOXN1 subjects should not be treated by either stem cell, hematopoietic stem cell, or thymus transplantation.
Perfect. I think we've alluded to this slide a couple times, but it was a really nice depiction of the diversity of either infections that were present or very notably not present. So this paper looked at the 16 patients listed there with the clinical notes on the right depicting the wide range of infections that were seen. So you can see patient 1 seemed to have a very severe phenotype with multiple viral infections early on in life, failure to thrive, and this patient died at 1 year of age from parainfluenza. And you can see that there were 2 deletions, the 2 deletions that were present in that patient. Patient 2 is one of the patients who was transplanted, who needed continuous B-cell help later on in life. And then you can see, there's several patients that they list that did very, very well. But then you can see kind of even small infections like a submandibular abscess versus patient 7 who died from coronavirus encephalitis. Patient 10 was interesting just because they also had a heterozygous DOC8 mutation, true and unrelated, obviously, but was interesting that they both had those. For patient 12 specifically, they talk about how that patient received live virus vaccinations and seemed to do well, had no issues with that. And then patients 15 and 16, they outlined that their counts were on the lower end until they kind of started to supplement their counts with what each patient received different therapy, and I'd have to go back and look to see what each one got, but it was outside the setting of transplant. So the only one that they had reported in this particular paper was patient 2 that received a transplant.
So there was a question by Yami Roat do the T cell count improve over time because of homeostatic proliferation? Yes, but there is also another reason why perhaps they improve. FOXN1 is absolutely critically needed during embryo fetal development of the thymus. It is also required in postnatal life, but I would say it plays a less critical role in postnatal life than it does in prenatal or very early in life. And so you could hypothesize that when FOXN1 becomes less critical in postnatal life, perhaps there is more opportunity to catch up with the lymphocyte count because you don't really need so much for thymic maturation at that point. But in general, yes, you do improve the T cell count largely because of homeostatic proliferation. I mean.
So the real clincher in this case was, as we looked further into this FOXN1 mutation, we went back and we talked to the family more extensively. And as we were describing FOXN1, it was clear that they had also done some Googling on their end, because Dad immediately showed us his toes and his fingers and some of the nail dystrophy or the nail changes that he had had. They report that Dad was in and out of the pediatrician's office at a younger age, up until about age 7, with just what they were calling frequent URIs and viral illnesses, never required hospitalization or workup for a severe infection. But this was kind of the key and another diagnostic clue for us, which prompted a lot of discussion with Invitae. I actually spoke with their scientific review team just this past week to discuss further this variant and the fact that we feel that this is clinically relevant and likely the cause of our patient's T-cell lymphopenia. And Invitae itself has kind of a scoring system in terms of how likely they feel a variant is to be pathogenic. And I believe they called it a Sherlock system. And they use a lot of what is in the literature currently, as well as what's being reported to them by providers. And that when a mutation gets a score of 5, then it's likely to be pathogenic. Whereas 4 is, they're considering it to be pathogenic, and they want the physician to the providing team to weigh in. And they said that this particular FOXN1 variant was hitting that 3.5 mark, but they were not able to get reported out as pathogenic. So I just provided them these extra papers to hopefully kind of push that down, and so that we can hopefully identify this as a new variant causing disease in these patients.
Saara, also thank you for showing toenails, because actually toenails are more important than fingernails. You more often see nail dystrophy on the toenails in these individuals than on the fingernails. So don't stop just at the fingernails. Look at the toenails.
So in terms of what we're doing for our patients, again, we're doing T-cell counts and kind of more extensive immune evaluations on a monthly basis in our patients. We're attempting to minimize infection risk as much as possible. We have discharged them to home, where the family is just keeping a very close eye on them. We had a brief scare with possible adenovirus, but both of them seemed to have enough immune barriers to kind of preventing any sort of disseminated infections. We are working up the dad and hoping to have further discussions with Invitae in terms of reporting this variant as likely pathogenic. And I think that is all I had.
Yeah, so there was I think an interesting question by Anthony Ayward, who was asking, so are these individuals more at risk for autoimmunity? And that's a good question, because of course you do need a well-structured thymus also to negatively select self-reactive T cells. And so you could, in theory, hypothesize that with a hypoplastic thymus, you might be at increased risk of autoimmunity, which is, has been seen also in the George syndrome, by the way, as you pointed out. The problem is that we don't have enough data on the heterozygous individuals actually, I only know of those ones of the adults that I reported in my paper, and we have a few infants now, some of which are between 3 and 10 years of life, but really not much follow-up. We could actually access the parents of those ones, like the parent you looked at in your family, and see is there more autoimmunity in these individuals than in the general population. I think it's an interesting question. I don't think we have the answer right now, but it's something that should be looked at, of course.
Yeah, it's interesting. Heather, I don't know if you had any additional thoughts with kind of where we're at with our twins.
Yeah, I mean, I definitely kind of agree that this variant is right on the cusp of being likely pathogenic, and there are guidelines provided to analyze variants and try to score them based on kind of weighted values. But always it requires some amount of decision making on the part of the pathologist and the clinical team as to what is sufficient evidence in the literature or in functional studies. And clearly now we have some functional studies to suggest frame shifts in this region are sufficient to alter function of the protein, both in vitro in assays, as well as some structural paper that was published this last year. And there are quite now a number of variants associated with a clinical condition that is similar to this patient.
Mm-hmm. Yeah, I agree. And maybe the take-home message here is that we're identifying more and more often FOXN1 heterozygosity, FOXN1 haploinsufficiency, basically, in newborns that have low TRECs and T-cell lymphopenia at birth. So this is something that should no longer be dismissed. In the old days, by old days I mean even a couple of years ago, people were not really giving much credit to FOXN1 haploinsufficiency because the dogma was that you needed to have biallelic variants, loss of function variants, in order to have disease. This is clearly not the case. On the other hand, many of these infants do pretty well, so I wouldn't even call this a disease, but they do require, as you pointed out, Saara, they do require careful monitoring and really active prevention of infections early in life. I also want to emphasize that one of the patients, one of these babies with FOXN1 haploinsufficiency developed a diffuse large B-cell lymphoma. So whether they are at higher risk also of malignancies remains to be seen. They clearly are at higher risk of infections, especially early in life. And so, again, this is not necessarily a benign condition. We have to look very carefully at these babies.
Thank you so much. Yasmin, I don't know if you had any
thoughts. I just thought that was a great case. I really, really enjoyed, working through it. And we got so nervous about these babies since they were twins and they both had such terrible T-cell counts to begin with. And then having Heather work with us was great as well. Thank you, Heather, for being on this webinar tonight. That was a great case, guys.
You have done a great job. May I ask a question? What was the parents' reaction? I mean, how did the parents react throughout all of these situations? I fully understand, and this is not an easy situation to deal with. You don't know exactly at the very beginning. You don't know exactly what it means, and of course, the parents are stressed because of this situation. How did you manage that?
I think it definitely kind of cushioned us delivering the news in terms of what this would mean for long-term monitoring, because we had already sent them home at that point. We felt that they had enough of a barrier to be safe in a protected environment at home. But they were excited to hear that there was an answer. I think Dad was fascinated to find that there was something explaining his nail changes that he's had his whole life. And I think I think they're just very eager to hear more about, long term, what this is going to mean for them and if it's going to mean anything. Dad's been difficult to bring back to clinic to do further testing on. But outside of the common cold, he seems to be doing well. No history of cancers or autoimmunity in him. But definitely we've had these conversations where we need to give them more time. They are excited to hear that there are cohorts of these patients that have been published, and that for the most part, infection control is our number one concern right now. So that they took it well. The initial postpartum, you need to come into the hospital because you may have SCID and need a transplant in 3 weeks, was a little rough, but as we got these results back, and felt more and more comfortable with their clinical course, they seemed to be comforted in knowing what was going on.
Terrific. Thank you.
Thank you so much. Thank you, everybody. Oop.
Thank you. One more question. What's the question here?
How does the
right. So, well, I haven't seen any of these heterozygous individuals having alopecia. Really the biallelic loss of function mutations, not the hypomorphic that Nick Van Ers described, but the ones that are really both alleles loss of function, they have a classical nude SCID phenotype, meaning that they have nail dystrophy, profound T-cell lymphopenia, and alopecia totalis. None of these individuals, none of those that I reported, and I think also all of those heterozygous that Nick reported, none of them have alopecia. So you basically have a dichotomy between the nail dystrophy, which many of these do have, and the alopecia, which they do not have. That's actually the difference. All right. Good
Perfect.
evening, everybody.
Thank you, everybody, so much. Thank you.
Bye-bye. Bye-bye.
Okay, guys, stick around for a few more minutes. We have, as the people that are on this webinar frequently know, we have a quick, hot new article to go through. This is not the hot new article. I think that would be too much to go through, but I wanted to bring everyone's attention to the fact that, we all use the IUIS phenotypic classifications of human inborn errors of immunity. I use it a lot. It is such a wonderful reference. There was an update published this month in the Journal of Clinical Immunology, so I would suggest that you go and look for it and get it printed out so that you have it. The article that I'm going to go through tonight quickly, just a couple of slides, was published in online in November. The title is Prophylactic Antibiotics versus Immunoglobulin Replacement in Specific Antibody Deficiency. The first author on this paper is Jude Hajar, who was on this committee with us, I guess, until last year. But it is an article that really made me think a lot about how we treat patients with specific antibody deficiency. I'm sure that you all see these patients quite a bit. In this article, they compared patients with specific antibody deficiency, which inherently means that they had a normal IgG level on prophylactic antibiotics versus those that were on immunoglobulin replacement at two centers, CHOP and Texas Children's Hospital. They had 65 patients. It was a retrospective chart review, which is inherently a limitation, but I still think the paper is great. And the main point of the article is that they found no statistically significant difference in infection reduction between the two groups. They did do a brief secondary analysis looking for variables that predicted persistent infections after treatment. And notably, they found that baseline IgG was important in predicting rates of infection, that for every 100 milligram per deciliter increase in IgG, the odds of infection significantly decreased with an odds ratio of 0.68. And then the presence of autoimmunity, a coexisting autoimmune disorder, had an increased odds of having infections, persistent infections after treatment, with an odds ratio of 4.29. And, the authors kind of postulated that maybe these patients who had coexisting autoimmunity were the patients that would go on to sort of evolve from specific antibody deficiency to CVID. So just to look at their figures quickly, this is a pictorial view of their cohort of 65 patients. Across the bottom on the x-axis are the different types of treatment. So some patients, 7 in fact, had no treatment, 7 received both types of treatment, patients that were on prophylactic antibiotics, patients that were on immunoglobulin replacement, and then a group of patients, 15 patients who failed prophylactic antibiotics and switched to immunoglobulin replacement. And there was no statistically significant difference between phenotype and treatment type. And then this is a pictorial representation of the mean number of infections. So at baseline, the group that was on prophylactic antibiotics had 4.71 infections in the year before they went on treatment. The group that was on immunoglobulin replacement had 7.73 mean infections, but there was not a difference between the two. And then the reduction in infections after treatment in the group that went on prophylactic antibiotics, they had about 3 fewer infections per year, while the group that was on immunoglobulin replacement had about 4 fewer infections per year. Again, not statistically significant. And this was, I thought, an interesting and important article for me. I don't tend to think about prophylactic antibiotics as much as maybe I should. But as the authors pointed out, especially in the era of potential immunoglobulin shortages and IVIG and subcutaneous immunoglobulin being used for different diseases and higher utilization, it is important to think about other ways to treat these patients. So I enjoyed it. I would encourage you guys to go and read it. Thank you, everybody. Have a great night, and we'll see you all in Denver in April. Good night.
Okay. Bye-bye.